Hello everyone, today's lesson is about tetanus. Tetanus is an acute spastic paralytic illness caused by the neurotoxin produced by Clostridium tetani, which is a motile gram-positive spore-forming obligate anaerobe. Natural habitat of Clostridium tetani is in soil, dust, and the elementary tracts of the various animals. And tetanus spores can survive boiling, but not autoclaving, whereas the vegetative cells are killed by antibiotics, heat, and standard disinfectants. Clostridium tetani is not a tissue-invasive organism, and instead it causes illness through the effect of a single toxin, which is called tetanospasmin, more commonly referred to as tetanus toxin, which is the second most poisonous substance known, surpassed in potency only by botulinum toxin. When we see the epidemiology of tetanus, the most common form, or neonatal or umbilical tetanus, it kills approximately 500,000 infants each year, with about 80% of deaths in just 12 tropical Asian and African countries. This occurs because the mother was not immunized in those areas. And 50 to 30,000 unimmunized women worldwide die each year of maternal tetanus that results from postpartum, post-abortal, or post-surgical wound infection with Clostridium. When we see predisposing factors for tetanus, most non-neonatal cases of tetanus are associated with a traumatic injury, such as penetrating wound inflicted by dirty objects, animal bites, abscess, ear on the body piercing, and chronic skin ulceration, burns, female circumcision, ritual scarification, and also rare cases have no issue of trauma. When we see the pathogenesis, introduced spore germinates and they multiply and produce tetanus toxin in the low oxidation reduction potential of an infected injury site. Toxin is released after vegetative bacterial cell death and lysis. Tetanus toxin binds at the neuromuscular junction and it enters the body. After entering the body, it reaches the neuromuscular junction and enters the motor nerve by endocytosis, after which it undergoes retrograde axonal transport to the cytoplasm of the alpha motor neuron. The toxin exits the motor neuron in the spinal cord, and the next it enters the adjacent spinal inhibitory interneurons, where it prevents release of the neurotransmitters glycine, GABA aminobutyric acid, or GABA. So the toxin inhibits the action of GABA. Tetanus toxin blocks the normal inhibition of antagonistic muscles on which voluntary coordinated movement depends. In consequence, it affected muscles sustain maximal contraction and cannot relax. The autonomic nervous system also renders unstable in tetanus. Because Clostridium tetani is not an invasive organism, its toxin-producing vegetative cells remain were introduced into the wounds, which might display local inflammatory changes and mixed bacterial flora. Because tetanus toxin does not affect sensory nerves or cortical function, the patient unfortunately remains conscious in extreme pain and in fearful anticipation of the next tetanus seizure. When we see the clinical manifestation of tetanus, the incubation period of tetanus is from 2 to 14 days, but it can be as long as 1 month after the injury. And it can be divided into two: generalized tetanus and the local tetanus. Generalized tetanus is characterized by trismus or lockjaw, which is due to masseter muscle spasm in the presenting symptoms in about 50%. Headache, restlessness, irritability are early symptoms, often followed by stiffness, dysphagia, and neck muscle spasm. Rhesus sardonicus, which is sardonic smile, results from interactable spasm of facial and buccal muscles. And epistotonus, which is arching posture due to involvement of abdominal, lumbar, hip, and the thigh muscles, which is board-like rigidity in which the back of the head and the heels touch the ground. Laryngeal and the respiratory muscle spasm can lead to airway obstruction and asphyxiation. Patient remains conscious in extreme pain and anticipation of the next tetanic seizure. Tetanic spasm may be triggered by the smallest disturbance, such as sight, sound, or touch. And high-grade fever can happen due to a catabolic state, and autonomic nervous system manifestations such as tachycardia, arrhythmia, labile hypertension, diaphoresis, cutaneous vasoconstriction can all occur. And the tetanic paralysis become more intense in the first week after onset and stabilizes over the ensuing 1 to 4 weeks. The other is neonatal tetanus. This tetanus neonatal or neonatal tetanus is infantile type of generalized tetanus, and it typically manifests within 3 to 12 days of birth, and difficulty in feeding, crying, paralysis, stiffness to touch with or without obstetricus are characteristics. When we see the case definition of neonatal tetanus, we say suspected neonatal tetanus in any infant with history of tetanus compatible illness during the first months of life, who fed and cried normally for the first 2 days of life, and any neonatal death in a child who could suck and cry normally during the first 48 hours of life is a suspected neonatal tetanus. And we say confirmed cases if there is a normal feeding and the crying during the first 2 days of life, plus onset of illness between age 3 and 28 days of life, and inability to suck, trismus, followed by stiffness such as generalized muscle rigidity, and also having muscle spasm. Localized tetanus is a painful spasm of muscles adjacent to the wound site, and this localized tetanus may precede generalized tetanus. And cephalic tetanus is a rare form of localized tetanus involving the bulbar musculature, and it follows wounds or foreign bodies in the head, nostril, or face, and occasionally it might follow chronic otitis media. This is characterized by retracted eyelids, deviated gaze, trismus, rhesus sardonicus, and spastic paralysis of the when we see the diagnosis of tetanus, the typical presentation is an immunized patient who was injured or born within the preceding 2 weeks, who presented with trismus, other rigid muscles, and a clear sensorium. And routine laboratory studies are usually normal, and the peripheral leukocytosis may occur if there is secondary bacterial infection, or it might be due to stress-induced leukocytosis. And the cerebrospinal fluid is usually when we see some differential diagnosis for tetanus, fully developed generalized tetanus cannot be mistaken for any other disease. Trismus might result from parapharyngeal, retropharyngeal, or dental abscess if it is the only present clinical manifestation at presentation. Rabies or tetanus follow an animal bite, and rabies might present as a trismus with seizure. However, rabies might be distinguished from tetanus by hydrophobia, marked dysphagia, and predominantly clonic seizure and pileocytosis. Hypocalcemia may produce tetany that is characterized by laryngeal and carpopedal spasm, but trismus is absent in hypocalcemia. When we see the treatment, eradication of Clostridium tetani and the wound environment conducive to this anaerobic multiplication is very important, and also neutralization of all accessible tetanus toxin is needed, and control of seizure and respiratory palliation is needed, and provision of meticulous supportive care is very important. And also, since infection by tetanus doesn't induce antibody that causes future prevention from this disease, so prevention of recurrence is needed by giving a booster dose of vaccine. When we see the complication, spasm and the seizures are the common complications: aspiration, pneumonia, venous thrombosis, pulmonary embolism due to prolonged bed rest, and gastric ulceration due to stress-induced ulcer with or without hemorrhage, and paralytic illness, decubitus ulceration due to prolonged stay in bed, and cardiac arrhythmias may also happen, and also labile temperature regulation can. Now, when we see the prognosis, the favorable prognostic signs are long incubation period, absence of fever, and the localized disease. Whereas unfavorable prognostic signs in tetanus include less than 7 days between the injury and the onset of trismus, and less than 3 days between trismus and the onset of generalized tetanic spasm, and cephalic tetanus are a poor prognostic sign. And case fatality rates for generalized tetanus are 5 to 35%, and for neonatal tetanus extend from less than 10% with intensive care treatment to greater than 75% without treatment. And the mortality is highest in the very young and the very old age group. When we see the prevention, vaccination of children and the childbearing women is the most important prevention mechanism, and the other is proper wound management, because if wounds are not properly managed, anaerobic environment is conducive to this bacteria. So vaccination and the proper wound management is very important in prevention. Thank you for your attention, and don't forget to subscribe this channel.